Hi, my name is Amanda Rosa, and today I'll be speaking to you about pulmonary fibrosis. So my patient was a 32-year-old female. There was a PA and a lateral view of the chest that was ordered. The patient had shortness of breath with a cough. The patient had Down syndrome and as well had an oxygen machine with them and a guardian. My interaction before starting the exam had asked the mother for the patient's information, her name, date of birth, and verification of what exam was ordered. The procedures had her remove all her jewelry that would be in the way of any anatomy, and also as well her bra. The critique on the film: positioning the patient, since it was a PA, I had her put her chest centered towards the IR, had her wrap her arms around the IR, roll her shoulders forward to remove the clavicles out of the way of the apices so they could be visualized. I had her position her chin upward. Her CR placement was perpendicular to the IR, centered at the level of T7. So this is right here her PA chest. The technique was 110 kVp, MAS of 6, 14 by 17 IR was used lengthwise. It's a DR system. SAD was at 72. Patient was standing. Collimation was the upper border to the vertebral prominence side to the outer skin margins. I placed a shield to cover the patient's reproductive parts as well. So for the anatomy that was demonstrated was the 10 ribs. Both lungs were visualized. Her costophrenic angles were seen, lateral borders of her ribs. But the image was missing the left marker. Up here should have been in the corner, but it wasn't placed. This is her lateral view. The technique was the same. Where I was, they didn't really double it, so it was the same thing. 14 by 17 IR lengthwise, DR system. The SID was at 72. Patient was erect, but I was collimating the upper border to level vertebral prominence side to the anterior and posterior skin. Position the patient erect left side against the IR. Arms raised above her head, her chin up, true lateral, there was no rotation. The mid-sagittal plane was parallel to the IR. Place a shield to cover the patient's reproductive parts as well. CR placement was perpendicular to IR, centered to mid-thorax at the level of T7. The anatomy demonstrated was her apices, costophrenic angles, full sternum, and posterior ribs. The body was not rotated. That was just the patient's anatomy. These are the results here by the radiologist. So the indication was a pulmonary fibrosis. And it says here it's a PA lateral view of the chest. It's speaking about the lungs revealed diffuse infiltrates consistent with previously described pulmonary CT findings. So I guess she had a CT prior to the day that she came in for her x-ray. So there was no focal consolidation or mass apparent. The cardiac contours enlarged. There's a higher prominence there, widening of the mediastinum. Evaluation of the CT in the chest performed around July reveals prominent mediastinum, and pleural surfaces do not reveal an indication. So I'm going to tell you a little bit more about that. So it was diffuse infiltrates we're speaking about. They were shown in the x-ray, which is a collection of fluid and cells on the image in the lungs. They are inflamed. Symptoms of someone who would have this are shortness of breath and cough. The fibrosis, the pulmonary fibrosis, is a disease in which the lungs become scarred and damaged, causing difficulty in breathing. It causes the lungs to thicken inside. Symptoms, again, are fatigue and dry cough. Then the cardiac contour was enlarged. So I'll show you all that after. The patient has an enlarged heart, also referred to as cardiomegaly. Symptoms for someone who has this is shortness of breath and a chest pain as well. Wide mediastinum, suspecting mediastinal adenopathy, is enlargement of the mediastinal lymph nodes, and the same thing is a cough and shortness of breath. So in conclusion, the reason for the patient's visit was shortness of breath and cough. After seeing the radiologist report, all the findings match with her symptoms. To further evaluate her diagnosis, she should get a CT scan to the lungs from top to bottom versus on the x-ray, you can only see the lungs from front to the sides. So as I was explaining before, in her lungs, we were talking about the cardiomegaly as the wide mediastinum and pulmonary fibrosis and infiltrates. So here, this is all the infiltrates that you can see here as well. And the wide in the mediastinum is right here in the middle. So it's pretty much just saying before, like I was saying, it was just the lymph nodes are all swollen. So this is the end.